Okay, so the third question we posed to you was really about a proposed duty of candour. We should explain what we meant by that. It was something that the Department of Health are consulting on at the moment to make providers have a duty to disclose when something goes wrong, to be open with patients and the public about what's happened and what they're doing to put it right. And that the proposal is to build that into the national contracting framework. Is that going to help? And should more to be done?
Well, it came out as part of our listening exercise, and as a doctor, for me, it means being honest with the patient. And actually, it's quite interesting when you're talking about the system as a whole and providers being honest. So it's sad that we've got to legislate for a duty when actually we should already have a culture of candour, openness, transparency, and particularly honesty between individual clinicians and the patient, between organisations. So what we were talking about is how do you provide and encourage the right behaviours and the right culture. And so we should use clinical commissioning groups, providers, but also monitor CQC and the regulators about how they can put this into their oversight and into the contracting to make it happen. And the more you're open and the more you are transparent, the easier it is when you get the challenges coming back. But it's a bit like dipping your toe into the cold ocean. You've got to get in there somehow, and perhaps this might stimulate a little bit of debate. We also thought about some of the other levers we could use. And the NHS Constitution at the moment is underused in these areas. So it's fantastic in that it gives a right to NICE approved treatments. But very few people out there in the community know about the Constitution and use that. I think it'll be increasingly used. And if we could put something in the Constitution about openness, that a patient should expect the system, whatever the wording, to be open, for everybody to be honest. But also taking the point made earlier on about national audits. If a patient can expect a nationally approved treatment from NICE, why shouldn't they expect to be cared for in a system where that system is involved in a nationally approved audit and quality improvement? And frankly, if it isn't, that organisation perhaps should not be a provider for NHS services, because it's voluntary at the moment, and actually unless we actually put the heat on, perhaps people won't go further. And the other point we made on the table, and I think the question was, what's the penalty if you are not candid? And short of putting people in the stocks, is it going to be a criminal offence? It needs some real teeth there, so that people can have confidence that this is real. Otherwise, why bother legislating? But we were very, very sad, I think, generally, that the culture isn't one of openness and transparency, sharing of data between practices and with patients, between hospitals and with patients. Until people are in that frame of mind, then we can't really move forward.
Okay. I mean, does that link back to the points at the table over there were talking about incentives in the contract? Do you think providers could try and incentivise providers to behave, commissioners could incentivise providers to behave differently around disclosure?
Well, I mean, that already exists to extent in things like best practice tariffs.
Yeah.
So that's a financial incentive to treat people in an idealised way, and the use of stroke units, for example, has been boosted by a tariff which pays extra if you go to a stroke unit. So there are mechanisms there already.
Yeah, the only thing I'd add on that, and I'm with both of you on where we're going, but we need the tariff to look, or incentives to look across the whole pathway, and particularly when you're looking at complexity. And it doesn't work at the moment. But if you're in a much more cooperative or integrated organisation, there should be incentives for all players, not just for the hospital or for primary care. We need to think in a much more mature way about how we fund the system.
I'm struck by, I just have the voice of some of the patients from Mid Staffordshire in my ear from yesterday, because they talked about it wasn't, once they'd made a complaint, once the trust had admitted that there was a problem, they said that wasn't enough. They wanted to be sure that something was done so it wouldn't happen to another patient. So whether disclosure is enough, whether it enables or encourages providers to then go that further stage to put the action plan and demonstrate it's working in practice.
Yeah, we talked about that as well, because it could be an unintended consequence of being completely open, that you're open and nothing happens. And it's just about quality improvement again, and that's why we talked about the audits and trying to get people to understand what that really means and what it's all about.
I know it's a superficial point, but does the word complaint get in the way? I mean, as a professional, we don't like being complained about. Who does? But also, it's probably putting off patients from complaining. You know, the 9 or 10 per formal complaint. Is it the negativity that's a real issue here? How can we build in a much more positive thing? When I was a young doctor, which was a long time ago, we were like, for want of a better word, brought up to say, don't admit anything. But all the evidence is that that's completely the wrong way, that
So
openness...
that was part of your training?
sort of informally. But on that micro personal thing, surely that's what organisations need to got into as well, that there's a positive thing here. But I wonder if the word itself is a sort of block.
Yeah.
It's
So
so negative.
comments might be better than
Or
complaints.
feedback, something, but then an ability to, you will be listened to, and that it's important to give feedback.
Okay.